All right, everybody. My name is Mrs. Fisher, and today we're going to go over respiratory overview and assessment. So what we see here is a detailed picture of the respiratory system. So you can see it from the larynx down through the trachea and into the lungs themselves. So what we're looking at right now is the respiratory system that is located in your thorax and then up through your throat and into your mouth. You have the spot here where the gas exchange happens. Blown up in this picture, you can see the alveoli and you can see the capillaries that surround the alveoli. So this is where the majority of that gas exchange is happening, and that's where that gas exchange is happening inside the alveoli. So you're inhaling the oxygen and it's coming down into the lungs, it's going down through those bronchioles and into the alveoli sacs. And these capillaries are carrying that deoxygenated blood that has the CO2. And here, this is where that oxygen and that carbon dioxide should exchange there from the alveoli into the capillaries, and then the capillaries should carry out the oxygenated blood to the rest of the body, and your alveoli should then take in the CO2, and the CO2 comes out when you exhale, right? So the majority of our oxygenation issues are coming from this spot. They're coming from something in here in the alveoli, or with getting air into the alveoli is where we're having an issue with the gas exchange, okay? Okay, looking over at the function. So function of the respiratory system, ventilation. So ventilation is the actual movement of air. That means when we take a breath in and we take a breath out. That is the ventilation. Now, respiratory rate or respirations, you'll hear it said both respiratory rate or respiration. A lot of people try to kind of interchange that with ventilation. However, respiration is actually the gas exchange itself. It's how many times we're exchanging gas per minute when we breathe, our respirations or our respiratory rate. So that's the actual exchange of the gas, the CO2 for the oxygen, and not just the actual movement of the air in and out of the lungs. Moving on over to acid-base balance. So your respiratory system is going to be your number one or your first mechanism of compensation for acid-base balance issues when we're talking about such things like metabolic acidosis or alkalosis, respiratory acidosis or alkalosis. The first thing that your body's going to try to do is use your respiratory system to either retain or to put off CO2, correct? So we're either going to increase our respirations or we're going to decrease our respirations in order to help get that acid-base balance back. So that's another big function of our respiratory system. Speech. When we speak, that air is going through our vocal cords, right? So it's moving through the vocal cords and allowing us to get that sound to come out. That sound coming out as it passes through the vocal cords is a big function of our respiratory system and the way we speak and how we speak at the volume that we speak. Your sense of smell. You have to have your respiratory system to be able to do that inhale and the exhale in order to smell things, right? Your sense of smell, that smell is carried on that inhale that you breathe in through your nose. Fluid balance. So we actually have a lot of insensible fluid loss from our respiratory system. We lose a lot of fluid when we breathe out. We got a lot of that droplet or some water loss that we have through our respiratory system. So you'll see us using that in order to try to help balance potential fluid loss because we do put off a lot of fluid that's maybe not accounted for with our respirations. And blood pressure. So blood pressure. So there's certain breathing techniques that we can do to lower our blood pressure. Um, Things like ACE expression, angiotensin 2 production, capillaries of the lungs. All of those things are going to be affecting BP. We don't see as much of an effect from BP due to the respiratory system, but do note that there can be some changes to your blood pressure due to things that we do with the respiratory system, such as like deep breathing techniques to try to calm us down, to try to help lower our heart rates and our blood pressure, okay? So, dead space or a shunt. So, physiological dead space, sometimes we have dead space in our body that is created there for a purpose, and then sometimes we have dead space that happens due to like damage in the lungs or damage to the alveoli. Um, Areas of the tracheobronchial tree don't participate in gas exchange. So talking about the tracheas or into the bronchioles themselves don't actually participate in the gas exchange. So those are referred to as anatomical dead space, meaning that they get air into them, but we're not doing any of that CO2 and O2 exchange. Now, alveolar dead space occurs when there is an impaired or absent respiration at the level of the alveoli. This occurs when there's like a lack of perfusion of the alveoli by the pulmonary capillaries. So physiological dead space is the sum of both anatomical and alveolar dead space. In patients with normal or healthy respiration function, physiological dead space is typically equal to the anatomical dead space. But when we see patients that have blood flows issues getting to the capillaries, or we're having issues actually getting air into those capillary or into those alveoli, and we're trying to get those alveoli to expand, or there's damage or there's congestion or something like that, sometimes those damaged alveoli can cause a shunt or a dead space. Ventilation perfusion mismatch. So what we've got here, if you're looking at this picture, you can have mismatch from two things. So ventilation mismatch looks, if you look over here to the left in the blue, you'll see that you've got perfusion. So you're getting blood flow without ventilation. So you see where you're showing a blockage of the alveoli. So what that means is we're getting blood flow, our capillaries are working, we're getting blood flow down and around those alveoli, but something is preventing us from getting air into the alveoli to be able to perform that gas exchange, whether it is like mucus, a blockage, congestion, damaged alveoli, whatever it may be, something is preventing us, like restricted airways, asthma attack, whatever it may be, is preventing us from getting air into the actual alveoli itself. So that is the ventilation. Um, Now, per, um, if we look at the other side, so you've got ventilation without perfusion, which means that we're getting air in and out of those alveoli, that those alveoli can move the air and our lungs can move the air in and out like they need to, but we're not getting perfusion, meaning we're not getting blood flow, correct? So what that means is we've got some sort of blockage in the capillaries, or we've got like a pulmonary embolism, something's preventing us from getting blood flow. We've got some sort of like vascular disease, whatever it may be. We're not getting blood flow down in those capillaries anymore. So even though we're moving air in and out, we no longer have blood flow that can then exchange the CO2 for the oxygen. Okay. So ventilation perfusion mismatch. You've got ventilation perfusion mismatch. To the left is perfusion without ventilation or a shunt. And on the right, you've got ventilation without perfusion, which is dead space. So perfusion without ventilation is a shunt. Ventilation without perfusion, dead space. Okay, perfusion without ventilation is a shunt. Ventilation without perfusion is dead space. Okay, so some of our gas exchange issues, we can really break these down into like four major categories. You would have hypoventilation, hyperventilation, decreased or damaged areas for gas exchange, and decreased perfusion. So hypoventilation, break down that word. So hypo means low, right? And ventilation is how we exchange air in and out. It's how many times we breathe in and breathe out. So hypoventilation um, is going to be due to like decreased respiratory status. So if our patients have like brain injuries, opioid toxicities. If we work too hard to breathe, we can start out with a rapid respiratory rate and then bring ourselves down into hypoventilation because our body is has worked too hard and we fatigued out. You can see fatigue causing that hypoventilation, um, and that's going to cause us to not take in enough oxygen, right? So if we hypoventilate, we're going to retain CO2. We're not going to be able to effectively do gas exchange that way. Hyperventilation, looking at that hyper means it's increased, right? So we've got an above normal respiratory rate. Hyperventilation, you see this in patients a lot with like panic attacks and anxiety. They hyperventilate and they breathe really, really fast and really, really hard. They go, you know how you see them, you know, we tell them like breathe into a paper sack because we're trying to get them to breathe in CO2. When you hyperventilate, you're not getting enough CO2 in. And so you actually will become alkalotic. So you'll see that in hyperventilation in patients like that that have anxiety or things of those natures. Uh, Decreased or damaged areas for gas exchange. So that's going to be that damage to that alveoli. That's going to be your COPDs, your emphysema, patients that chronically smoke. If you've got some sort of like congestion, fluid, or atelectasis, where the alveoli can no longer like expand and contract like they need to, that's going to cause that decreased or damaged area for the gas exchange. And then decreased perfusion. So that's that lack of blood flow, right? We're for some reason not getting blood flow down to the capillaries anymore. That's your pulmonary embolisms. That's your blood flow issues in your patients that have damaged blood vessels from like smoking, um, high blood pressure, things like that. Okay. All right. Assessment. So assessment, should be review from your health assessment class that you've already taken. But what we're looking for here is that we're going to take questions about current illness, health history, family history, social history, and then you're going to perform your actual physical assessment. Okay. So when we're talking about current illness presentation, you want to ask the patient questions, you know, so what brought you in? What symptoms are you having? Why do you feel this way? Have you, you know, how long has this been going on? When did the symptoms start? What makes your symptoms better or worse? You want to ask those good initial questions. And then moving into health history, you want to know, do you smoke? If so, how much do you smoke a day? Did you smoke today? Calculate your pack years. Medications. So some medications can affect our respirations and our lungs. So we need to know what meds they're on, past medical history, both social and medical. So if we're, you know, a firefighter and we get exposed to a lot of house fires and now we're having breathing problems, that's good social history to know, right? Same with medical history. Do they have history of COPD, asthma, allergies, whatever that may be? Family history, you know, we're going to ask family history. Did you have anybody in your family that has lung problems, been diagnosed with lung disease, lung cancers, things like that? Social history is going to talk about exposure, travel, occupation, and area. So like we talked about there. And then assessment. So when you're looking at your patient, you're going to, you know, inspect, means you're going to look at your patient first. So when we're looking at our patient, we're looking for respiratory rate, depth, the effort. Are they using accessory muscles, meaning that you're seeing like potentially like retractions, or you see them belly breathing, you see that, you know, work in their abdomen. Do you see nasal flaring? Do they have an abnormal breath pattern? Do you see them sitting in a certain position, like tripod positions or things like that, or sitting up in order to catch their breath? Are they winded or short of breath just talking to you, or, you know, getting up to walk to the bathroom out of the room? Also look for like mental status changes, restlessness, agitation, confusion. A late sign would be like extreme lethargy. Usually your patients will get agitated and more ramped up when they feel like they can't breathe before they give up and get lethargic. Usually when they give up and get lethargic, that's a bad sign. When you're doing your assessment, you're looking for fever. Ask them about their sputum. If they've got sputum or secretions coming up, is there blood in the sputum? Or is it purulent? Or is it clear? Is it thick? Or is it runny? You want to look for a tracheal deviation. So the trachea deviates usually to the unaffected side. We'll talk more about that later on. But looking at that trachea, see if it's midline or if it's deviated to one side or the other. Ask if their cough is productive or unproductive, how long they've had the cough. And then crepitus, you remember how we feel for crepitus? We feel that's almost like that Rice Krispie feeling that you get when you palpate the chest. It feels like what Rice Krispies sounds like, if that makes sense. That's that popping you would feel in the chest, meaning that there's some air in there. Look at their thorax symmetry. Like we talked about, inspect the thorax so you can get a good idea of if they're using those accessory muscles or if they're having increased work of breathing. Look at the nail beds for cyanosis. Look around the mouth to see if you see any blue or cyanosis there. Their mucosal membranes, are they dry? Or are they blue? Are there, are they getting good color in their fingers, or are their fingers blue? You can look for signs of hypercapnia, which would be like headaches, dizziness, lethargy, inability to follow instructions, disorientation, or a late sign would be coma. That would be bad. We can monitor the oxygen saturation using those pulse oxes, and things like that. Okay. Also, when you're doing your palpations, feel if they feel warm. What's their skin turgor like? And then auscultation, you guys, if you haven't listened to lung sounds in a while, you haven't heard some abnormals in a while, please refer back to this video and give them a listen. You are expected to know the lung sounds. This is going to be moving forward for everything you do in nursing. You need to know and understand your lung sounds. It's okay if you're not familiar with them, please listen and get familiar with normal so that you can identify what abnormal sounds like. And then from when you can identify abnormals, then we can break that down into this is rhonchi, this is crackles, this is wheeze, so on and so forth. Okay. Definitely listen to those lung sounds. Get comfortable listening to your friends, your family, to identify normal. That way you can for sure be like, I know what normal sounds like, and that does not sound normal. Okay. Other things to know, you can assess ABGs on your patients. So ABGs are going to tell us, our blood oxygenation. It's going to be how we can look for like respiratory acidosis, alkalosis, things like that, our pH balances. Also some things in assessment, ask about if they're having any pain with respiration. So do they feel pain when they take a deep breath, or do they have pain when they exhale, sharp pains, dull pains, aching pain, that kind of stuff. All right. You are expected to know the normals here. So you need to know the normal respiratory rate of 12 to 20. You should want to know that their respiratory effort is normal, which means at rest, we should not have any effort to breathe. We should have relatively easy breaths within that normal depth and rate. Lung sounds, like I talked about, get comfortable knowing your normals so that you can help identify abnormals. The chest, we should expect to not see any barrel chest or accessory muscle use. Their chest movement should be symmetrical, making sure you don't see like flail chest or like paradoxical movements where one side of the chest moves more than the other when you breathe. So get comfortable with inspecting the chest. You're going to have to like lift your patient's shirts and stuff, okay, to get a good inspection of the chest. Color, is their skin color appropriate for that patient, for their race, ethnicity, whatever it may be. And energy level, are they at a good energy level? Or are they starting to look lethargic, or are they starting to look like anxious, ramped up? Some of those can be signs of respiratory distress. So make sure you know how to identify normal, like I said, so that you can then be like, I know for sure whatever this is not normal. Okay. Okay. Terms. So these are your terms. You are going to be expected to know these terms, so get familiar with them. Some of these should be review, but we'll go ahead and break down some of them. Tachypnea. So if you see tachy in tachypnea, that's when we are increased respiratory rate. Obviously, we talked about use of accessory muscles and restlessness, confusion, decreased levels of consciousness. So that means we're, presenting with that lethargy, confusion. Maybe we're even hitting more of that comatose like state. Fever, and then sputum. You guys know that sputum is um, that secretions that come up when we've got secretions in our lungs. So hemoptytosis is coughing up blood. That's like when you've got blood coming up in your mucus. Purulent's going to be that, drainage that is yellowy infection like thick, sticky sputums. Tracheal deviations. Remember how we talked about the trachea in your, so you should be able to, identify the trachea looking at the throat. Deviation means it's moved off of its normal midline. If you are experiencing issues with the lungs, usually if you're to the point of tracheal deviation, it's going to deviate or move to the non-affected side. Okay. Orbital edema, redness and warmth. So that's that orbital edema we know is like that swelling around the eyes. We'll talk about that. That'll be more important as we move on into other lectures throughout this module, but definitely need to monitor and assess for orbital edema, which is, swelling or edema of the eyes. Barrel chest. So barrel chest is exactly what it sounds like. It's where your chest is no longer in that normal diameter where it should be 1 to 2. So the front of your chest um, being larger than the side of your chest. So looking at the front versus the width. A barrel chest is where you actually end up with a 1-to-1 ratio. So it literally is round like a barrel. We see this in our patients with like COPD, guys. Those people that have that damage to that alveoli, they'll end up with that barrel-like chest that goes from being flat in the front with your rounded sides to pretty much being a round barrel all the way across. And then you've got, cough, crepitus, hoarseness. You guys are familiar with that. Paradoxical chest movements or flail chest. Paradoxical chest movement or flail chest means that when we breathe, our chest does not move symmetrically. You've got one side that moves and one side that doesn't, or maybe even one side that concaves while the other side comes out. That's usually a sign of trauma. Your patient has some sort of trauma to their chest. That is an emergency. You need to be able to identify paradoxical chest movements, okay? So cyanosis is that bluish color that you get to the lips and skin, mucosal membranes. Hypercapnia refers to the excess of carbon dioxide in the blood. So that's like your COPD patients that retain that. Hypoxia is the lack of oxygen in the tissues. Okay, hypoxia and hypoxemia are different. Hypoxia is the lack of oxygen to the tissue. Hypoxemia is the lack of oxygen in the blood. Emia meaning blood. Okay. Clubbing of the fingernails, so they literally will get rounded. And club like you'll lose that triangle there in the nail bed. They will club. Decreased SpO2, increased PaCO2, decreased PaCO2. You guys are familiar with those. Elevated white blood cell counts. So obviously that can be signs of infection in our patient. And especially if we're dealing with respiratory issues, pneumonia or things of that nature, we need to be familiar with that. Low H and H or your hemoglobin and hematocrit. Okay, so if your hemoglobin is low. Hemoglobin is how we carry oxygen through the body, right? So if you don't have enough hemoglobin to carry oxygen, you're gonna have low oxygen throughout the body. So that's going to affect your body's respiratory rate. It's going to want to try to take in more oxygen because it's trying to get more oxygen throughout the body without enough hemoglobin to carry it around. So that's going to cause low oxygen levels, okay? Respiratory acidosis. So, when we talk about acidosis, we're looking at that pH balance, the 7.35 to 7.45. Uh, Respiratory acidosis, like we talked about, happens when we retain too much CO2. Respiratory alkalosis happens when we have too much oxygen. Chest pain with coughing, um, so sudden onset chest pains that are worse with taking a deep breath, or pleurisy. So that's pain that we get, pleuritic chest pain. Um, so you've got the pleural, space there in the chest, and we get that pleurisy. So Beck's triad is something that you get with like cardiac tamponades. So we'll get into that a little more later, but Beck's triad is going to cause that muffled heart sound, hypotension, distended neck veins, like the JVD. So be aware of that. So that mediastinal shift is that tracheal deviation going off of the mediastinal. Like we said, it shifts usually to the unaffected side. Absent lung sounds, obviously that's bad. If we got absent lung sounds, we're not moving air into that lung, something's blocked, it's collapsed, whatever that may be. So crackles. So looking back on our lung sounds, so crackles are gonna be due to fluid in the lungs. You're gonna hear, like we talked about, you're literally gonna hear like crackling and popping in there. Your lungs are wet, you've got some sort of fluid in there. Wheezing is usually inflammation based, so you've got some inflammation, and you can hear that like inspiratory or expiratory wheeze. Patients that have asthma, you may hear that inspiratory or expiratory wheeze on them. Bronchi is more like a low pitch, so instead of crackling, it's more of like a rattling or snoring sound. Um, and it can also be caused by like fluid or mucus obstructions, pneumonia, bronchitis, things like that. Sometimes that bronchi will go away when you can cough up that mucus. Inability to speak in full sentences. So remember how we talked about like we need air in order to go through our vocal cords to get our voice to come out and get the sound to come out. If your patients are so short of breath that they're not able to speak in full sentences without trying to catch their breath, that's a bad sign. Okay, guys. So make sure you're paying attention to that as they're talking to you. Are they having chest tightness? Penetrative injuries will cause like that sucking sound. So if you got like literally like a penetrative injury would be like a hole in the chest. You got stabbed in the chest with something. Malaise, fatigue, pack years. So pack years is how we calculate how like much your patient smokes. So pack years is done with packs per day times the years smoked. So if your patient smokes 2 packs a day and they've been a smoker for 20 years, they are they have pack years of 40, right? So it's the packs per day times the years smoked. So if they smoke 1 pack a day for 10 years, their pack years are 10 years. Okay. Pursed lip breathing. So, it's, the positioning of the lips. If your patient's pursed lip breathing, trying to catch their breath. Reddened or flushed skin, looking at some bilateral infiltrates on the chest x-rays. I think barrel chest ended up on here twice. Sorry about that. Headaches and sinus pressure, um, rhinorrhea. Rhinorrhea is a runny nose. So that's like if you've got those seasonal allergies that clear drainage that comes out of your nose. Myalgia, that muscle pain, soreness, aching. Steatorrhea is that like fatty stools. You'll kind of see that in your patients with cystic fibrosis. We'll talk more about cystic fibrosis as we get there. Same with that mucus plugging. We see that mucus plugging in cystic fibrosis, and it prevents being able to move air in and out of the lungs. Okay. All right, lab. So we talked about ABGs, your arterial blood gases, right? So you guys have got to know you are responsible for knowing your levels of PaCO2, your pH, your HCO3, and your O2, what's acceptable so that you can identify if they are acidotic or alkalotic, and then obviously knowing, respiratory and metabolic, here we're focusing more on respiratory. Remember the acronym ROAM, respiratory opposite. Metabolic equal. For this, we're just looking more at the respiratory aspect. Remember, we talked about the respiratory system usually is your body's first compensatory mechanism for trying to correct your acidotic or alkalotic states. So by increasing or decreasing our respiratory rate, increasing our respiratory rate will make us more alkalotic. Decreasing our respiratory rate will help us retain more acid to become acidotic. So remember that usually your respiratory system is the first way that we are doing that. Diagnostic. Okay, so when we're looking at diagnostic, obviously the first diagnostic that we have is a pulse ox, correct? So we've got that pulse ox. You're gonna put it on your finger. It's gonna give you a pulse ox reading. Usually we're looking at like 95 or above for your normal healthy patients. Abnormal pulse ox readings, in 93s, 94s maybe not be too concerning. We really want your patients to be maintaining above or in the 90s. If we start hitting, 90 or lower in patients that are considered, or deemed healthy patients, we might be getting concerns for hypoxemia. Anything less than 85 would be like severe, hypoxemia, because we're looking at the level in the blood, right? When we're putting that pulse ox on, it's reading the oxygen levels in our capillaries in our blood. So we really want to make sure that we know how to read our pulse ox, that we know if our patient, is somebody that we would expect to have lower pulse oxes. Patients like COPD patients may have chronically lower pulse ox readings, and we'll talk more about that when we get into that, about how sometimes it's okay for them to sit a little bit lower because we can't give COPD patients a lot of oxygen. We'll get into that a little more later as we talk about that. But just know that usually we want to see our patients, especially normal healthy patients, sitting at like 95% or better, okay? Capnography is continuous monitoring of the PaCO2 in the airway during inhalation and exhalation. It provides a written tracing. So you'll see us put like capnography on patients when we do conscious sedation or something like that, be able to trace how much CO2 they're putting off to make sure that they are still oxygenating appropriately, even though we have done sedation. Like in the ER, you might put conscious sedation in for a patient that needs to have like a elbow relocated, so they've dislocated their elbow. We got to pop it back into place. We'll put a capnography reader on their nasal cannula, and it'll help monitor that they're still exchanging good CO2. Okay. Capnometry measures the amount of CO2 exhaled without continuous tracing. So one is just like a snapshot. The capnometry versus capnography is like continuous monitoring. Like I said, you would see that in like conscious sedation patients. Sputum analysis, they can take the sputum and take samples of it. They can look at it under the microscope. You'll see sputum analysis for like diagnosing tuberculosis, things like that. Chest x-rays, obviously you guys should be familiar with what a chest x-ray is. We're going to look and it's going to help us see if we've got pneumonia, fluid in the lungs, infiltrates, things of that nature, okay? Or like a foreign body in the lungs even, something like that. So pulmonary function tests evaluate the lung volume to determine the function of the lungs. The patient is asked to inspire and exhale into a mouthpiece. During the test, the patient is given instructions to alter his or her breathing patterns, allowing for the different tests to be obtained. Before the test is started, normal values are based on like gender, weight, height, smoking history. It's all included to create more accuracy. If you have abnormal values, pulmonary function values aid in like diagnosing respiratory conditions. You'll see like pulmonary function tests done before patients can have certain procedures to determine that their lungs could handle like being intubated and extubated. So you might see pulmonary function tests done on a lot of your patients that are in the hospital or your patients that are there for like respiratory or heart problems, okay? A bronchoscopy is actually like direct visualization of the respiratory tract at the level of the secondary bronchi. So it's actually like insertion of a small camera or a scope on a flexible and rigid end. Um, when they go in there, they can look with the camera, but they can also like take samples or even like remove obstructions when they do uh, bronchoscopies. I think they're pretty cool. A thoracentesis. Thoracentesis is going to be a diagnostic test where we actually drain excess fluid off. A needle's inserted into that pleural space. Remember how we talked about like pleurisy, that pleuritic chest pain? Sometimes we'll get fluid built up in that pleural space, and your patient will need a thoracentesis. Air as well could also be removed that way. Stick a needle in and we drain it off. They can actually like test and sample that fluid for like infection, blood, whatever it may be that they're looking for. And your patients usually feel much better once they get that fluid drained off of them. They feel like they can actually take a deep breath again. They'll look for like abnormal cells to see if we need to treat with antibiotics or if there's air. That could be like a pneumothorax diagnosis. So that's what we're watching for there to make sure we're not like air leaking in there. Fluid doesn't come out, okay? And then lung biopsies, you guys should be familiar with the idea of a biopsy. So that's going to be where they sample the tissue. They'll go in and do that for like diagnosing lung cancer and things like that, okay? Or infectious processes, malignancies, things like that, okay? All right, nursing interventions. So position, ambulation, turn cough, deep breathe, oxygenation, BiPAPs, CPAPs, ventilators, incentive spirometers, medications, breathing and coughing techniques, suction, management of fatigue, consider the need for ventilation, limit respiratory infection exposure, education, and psychosocial support. Okay. So first going into positioning. So when you're looking at this in NCLEX World and you're getting that question on a test, you guys got to remember that sitting somebody up or like putting the head of the bed up is actually an airway intervention in these questions. Okay. So remember how we talk about our ABCs, airway, breathing, circulation. You might get a question, that gives you a list of options and says which is best for this patient that presents with like acute signs of difficulty breathing. And one of those questions or the answer options may say to elevate the head of bed 30 degrees, put the patient in high Fowlers, whatever it may be. Remember that that is an airway intervention that you can do. One of the first things that we can do for our patients when they are struggling to breathe is sit them up. Tripod, leaning forward. You can have them like lean forward, onto their knees to help catch their breath. We talked about that, like high Fowlers and semi Fowlers. We don't want our patients to slump because slumping will compress the diaphragm. Reverse Trendelenburg. So reverse Trendelenburg is where we take the patient and so Trendelenburg would be to tilt them back onto their head. Reverse Trendelenburg would be to actually tip them forward where their feet are lower than their head while they're still laying flat or prone. And then prone, you see that too. So reverse Trendelenburg bringing them with their obese helps get that weight off of them, kind of gets that weight off of their chest. But a prone position, we saw this in COVID a lot. Um, that prone position helped make sure that the anterior um, alveoli got that ventilation and got that blood flow. Ambulation, encouraging your patients to ambulate. Having your patient get up and move around is so good. Turning them Q2 hours, it's going to help get the airflow. It's going to help break up any mucus or congestion. Uh, it's going to help them get those good deep breaths in. Like, so they're not, we talked about like being hunched over or like trapping your chest where you can't get a full deep breath. Definitely encourage ambulation. Turn, cough, deep breathe. That's, that turn Q2 hours. Have them perform controlled coughing. Have the patient inhale deeply, hold the breath for several seconds, and cough 2 or 3 times with the mouth open while tightening the upper airway and abdominal muscles. Encourage slow, deep breathing. The use of incentive spirometer. You guys are going to be responsible for knowing how to use an incentive spirometer, okay? There is a link to a video here in the PowerPoint. Please watch that video and get familiar with that. You are responsible for knowing how to use an incentive spirometer, okay? And how we educate our patients on doing that. Oxygen delivery. So obviously oxygen is a medication. Oxygen has to have an order, but us as the nurse, we can follow through with the order. We can assess and get in touch with the physician if we feel like we need to change modalities of oxygen or if we need to increase oxygen. So, knowing your oxygen devices, we'll talk about those here in just a second. Avoiding high concentrations in COPD patients. All right, let's have that conversation. So avoiding high concentrations of COPD patients getting a lot of oxygen. So in your normal patients, the drive to breathe is based on exchanging that CO2 and that oxygen. When we give our patients too much oxygen that have COPD, their drive has switched and they are no longer um encourage their body doesn't encourage them to breathe due to too much retained CO2 because they have chronically retained CO2. It's actually their respiratory drive is based on oxygen. So if we give them too much oxygen, your patient's respiratory drive will decrease. You will actually decrease your patient's respiratory drive in their respirations and COPD. Because their body no longer triggers them to breathe based on retention of CO2, but it's actually to the exposure to oxygen, okay? So make sure, that's what we talked about. Your patients with COPD may have slightly lower pulse oxes, and we might be okay with them living at slightly lower pulse ox readings because especially if they're coming in with shortness of breath or a COPD exacerbation, if we give them too much oxygen, we're at danger of decreasing their respiratory drive altogether, okay? Mask to nasal cannula before meals rather than removing. So obviously, if our patient still needs oxygen, but we need to function, we need to do things, we need to walk to the bathroom, we need to be able to eat food, we can switch the method of delivery instead of just like turning the delivery off altogether. So BiPAP. So BiPAP is bi-level positive airway pressure. If you guys have ever seen your patients who put on a BiPAP or seen a BiPAP at the hospital, a BiPAP essentially is giving positive pressure all the time. Your patients put it on their face and it's hooked up to that ventilator machine that gives that airway positive pressure all the time as they breathe. And so it's forcing that airway open, regardless of the breath. Or sometimes we could do like assisted where it gives a breath when they take a breath. So CPAPs are more so on that idea. CPAPs are usually for like obstructive sleep apneas. You usually only see a CPAP for sleep apnea because it's essentially giving assistance based on the patient's breath to keep the airway open rather than continuous positive pressure, okay? Ventilators, obviously you got endotracheal tube and tracheostomy tube, so that's if they're intubated through their throat or if they've got a trach and they've got a tube there, the ventilator and the ventilator settings are a nursing intervention. Usually respiratory therapy will also work with you with your ventilation and your ventilator settings, but get familiar with knowing that. Medications, so There's certain medications we know that we can give to help open up the airways, such as corticosteroids for inflammation, like Solumedrol. Your patients may have inhalers ordered, so be familiar. Usually in the hospital, we don't give like albuterol updrafts or we give inhalers, but they are on your MAR. It is important for you to know. You can consult respiratory therapy to help get your patients breathing treatments when they need them. So be familiar that there are nursing interventions that you can do medication-wise to help open up your patient's airways. Breathing, coughing techniques, pursed lips, forced expiratory, manual assisted cough. Watch the videos on those. Get familiar with those. Suction. If your patient has a lot of secretions, they're coughing up a lot of sputum or they've got like a lot of secretions coming from their mouth, get suction on board, guys. Get the suction hooked up in your rooms. Make sure your patient has access to that so you can help suction out that airway so that they're not getting lack of airflow due to not being able to get those secretions out of their mouth. We talked about monitoring for fatigue. So we need to like block or cluster our care. You guys, I don't know if you've had pediatrics yet, but it's something we do in pediatrics to like not overstimulate and overwhelm our babies and get them really upset and increase their respiratory rates and their heart rates. Clustering care, you can do this with your adult patients as well. When we cluster care, it means that we try to knock out a lot of our tasks all at once so that we're not disturbing or interrupting this patient 5, 6, 7, 8 times in a row. Clustering that care is going to decrease the labor that they have to do, their stress. It'll help keep those respiratory rates low, and that they don't have to do as much effort like getting them up, moving them around, and that kind of stuff. Plenty of rest periods if you do have to get them up, if you do have to move them around or to do their assessments, make sure you give them plenty of rest in between things as you do them. Obviously, limiting respiratory infection exposures. Really follow your airway and droplet precautions. Try not to expose your patients that don't have infections to the germs of your patients that you're caring for that do have infections. So making sure that we are following appropriate hand hygiene, that we're wearing masks when it's appropriate, things of that nature. And education and psychosocial support. It's really important that we help try to decrease our patients' anxiety. Not being able to breathe can make you really anxious, guys. I don't know if you've ever felt like that. I don't want to feel like that. But your patients that cannot breathe can get really panicked, and it can be really frustrating for them. So make sure that we're trying to create like therapeutic environments and things like that in these patients' rooms, along with that clustering care is a great way to do that, okay? All right, oxygen delivery devices. I'm not going to hit too hard on this. You guys should be familiar with these. Just know that room air is FiO2 of 21%. Every liter per minute that you go up, it adds an additional 3%. So like 1 liter a minute is 24%, and then you add 4. So then you would go 2 would be 28, 3 would be 32, etc. So once again, you start at a room air of 21, 1 liter of oxygen adds 3. So that's 24%, and then you go up 4% for every additional liter a minute that you add there. So low flow oxygens are going to be like nasal cannula. You should know you can do 1 to 6. If you're needing more than 6 liters of oxygen, and you're on nasal cannula, you need to move to a different type of oxygen delivery device. Usually after a couple liters, if your patient starts to get dried out, we could do like humidified oxygen to keep that oxygen from drying out their mucosal membrane. Same with like high flow. If your patient's on those high flow nasal cannulas, they will get humidified oxygen. Simple masks is at 5 to 8. Partial non-rebreathers are 6 to 10. So a non-rebreather, the big takeaway on non-rebreathers that I want y'all to know is you have to have that filled up with 10 to 15 liters per minute of oxygen going. If you don't turn up your oxygen dial to that anywhere to that 10 to 15, that bag on the non-rebreather is not going to inflate all the way, and it's actually essentially going to be like suffocating your patient because they're not going to be breathing in oxygen. Okay. High flow, more precise, proper fittings. You've got the Venturi mask, the aerosol face mask, or tracheostomy collars, the T-piece, and the high flow nasal cannulas. Just know that those can go up to 60 liters per minute. We talked about they create some positive pressure, usually humidified when we get up into these higher flow rates. Just kind of look over these and get familiar with them, okay? All right, oxygen device risks and complications. So, oxygen is a medication. Remember, I said that earlier. It has to have a physician's order. We don't just give oxygen willy-nilly because we want to. We can cause oxygen toxicity. It's not super common, but ongoing therapy, it's usually when you see it like in at least they've had it on for 24 hours and that they're at an FiO2 of above 50%. So they're on those higher flow, like high flow nasal cannulas or things like that, or those higher level device delivery. Um, Signs and symptoms of that are going to be a non-productive cough, substernal chest pains, nasal stiffness, nausea, vomiting, fatigue, headaches, and sore throat. So O2 induced hypoventilation, that's what we talked about our COPD patients, that we decrease their respiratory drive because we've given them too much oxygen. So they are not breathing enough hypoventilation, meaning they're not taking enough breaths in and out. So patients that have chronic hypoxemia or hypercapnia, like we said, is that retention of CO2. Our biggest concerns with oxygen delivery is combustion. Oxygen is very flammable. I don't know if you guys have seen it. I've seen several patients in my time in the ER who smoke with their oxygen on and they come in with facial burns because they blow their oxygen up in their face. And I promise you, if they've done it once, they'll do it more than once. But there needs to be no smoking or open flames near oxygen. You need to know where the fire extinguishers are. If your patients are on home oxygen, they need to have a fire extinguisher at home or be educated on the fact that it's flammable. No synthetic or wool fabrics, use cotton instead. Ground electricity devices and electrical devices work well. No alcohol, acetone, petroleum near the CO2. So, like Vaseline, don't let your patients put Vaseline on their lips or on their nose to help prevent drying out their mucosal membranes. Their nose feels dry. Um, Vaseline is flammable. It'll catch their nose on fire or their lips or whatever's close to their nasal cannula or whatever oxygen device they are on. So really make sure that your patients are educated about how to prevent their oxygen from combusting or catching fire. You will probably see it sometime in your nursing career where somebody has blown their oxygen up in their face by not following these rules. Okay. All right. Usually we have a few main goals. Obviously, we want to maintain optimal gas exchange. That's like our biggest goal with respiratory problems is that we want our patient to be getting effective oxygenation. We're wanting to get rid of CO2 and have enough oxygen and keep balance and homeostasis. So we're going to monitor ABG levels, SpO2 levels, and respiratory rates. Absence of infection, we either want to prevent the infection from happening in the first place, or we want to reduce or get rid of the infection that is taking place that is causing the respiratory issues. So those are the major goals. And then obviously we want to reduce or completely get rid of the symptoms. Sometimes patients like COPD, emphysema, asthma, may never truly have relief of symptoms. They may never feel 100% better or not feel short of breath when they get up and walk, go up and down the stairs. But just know that that's your major goal is sometimes we can get our patients back to baseline, back to normal. Sometimes we can't, and sometimes we have to have realistic expectations with our patient of just getting them back to their best level of function despite their condition, okay? And additional terms, compliance is the elasticity slash expandability of the lungs and thoracic structures. Pulmonary effusion is the process of exchange. Oxygen and CO2 moves from high to low concentration. Pulmonary perfusion is blood flow through the pulmonary vasculature, right? So diffusion is the process of the exchange of oxygen and CO2, and perfusion, pulmonary perfusion, is blood flow through the pulmonary vasculature. Lung volume, tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. Tidal volume is the volume of air inhaled and exhaled with each breath. Inspiratory reserve volume is the maximum volume that can be inhaled after a normal inhalation. So you take a breath in, just a normal breath, and then how much can be inhaled after you've taken that normal breath. Expiratory reserve volume is the max amount of air that can be exhaled forcibly after a normal exhale. So that's exactly what it sounds like. You took a normal breath out, and then how much more could you force out after? Residual volume is volume remaining in the lungs after maximum exhalation. So you've exhaled as much as you possibly can, and how much is still hanging out in your lungs, keeping those alveoli open. Lung capacities. Vital capacity is the maximum volume of air exhaled from the point of maximum inspiration. Inspiratory capacity is the max volume of air inhaled after normal expiration. Functional residual capacity is the volume of air remaining in the lungs after a normal expiration. And the total lung capacity is the volume of air in the lungs after a maximum inspiration. You guys can kind of look over those and get familiar with those. Okay. All right. Thank you.